Bianca, can you pull up the slides? 1 second. Yeah, here we go. All right, welcome everybody to today's policy briefing. I'm just going to take another second or so to make sure that everybody can log on, but I know that we want to quickly jump into this presentation. So today's our policy briefing, the future of interoperability management. EHI puts on these policy briefings every month to really showcase the innovative and awesome work that our members are doing. So be on the lookout. We have some coming up. As a reminder, we want to hear from you guys. So make sure that you are commenting and putting your questions and your thoughts in the Q&A and chat box so that we can ensure that Anita and Amanda see those. Again, I want to welcome everybody to our policy briefing today, the future of interoperability measurement. I am Emma Valinsky-Lloyd. I'm the Director of Policy and Programs for the Executives for Health Innovation. I am joined today by Amanda Patnow, the Managing Partner for Coda Creative LLC and our Senior Policy Analyst, and also the co-founder and CEO of Clinovations Health and Government, one of our great members here, Anita Samarth. If you could just go to the next slide, Bianca. Really quick, for those who are new here, we are the Executives for Health Innovation. We are a convener of experts and executives from all across the healthcare industry. We bring people together, we facilitate conversations, and then with those insights, we create educational materials and events to distribute this stuff out to you guys, out to the public. So like think webinars, policy briefings, reports, work groups, etc. We're also a membership organization. So if you could go to the next slide. As you can see, our membership is also varied and vast. So if you see your company name on here, know that you are also a member and we'd like to get you involved. And if you don't see your name up there, but you'd like to see your name up there, we would also like to see your name up there. So you can also put that in the chat and we can connect. Next slide. All right, so as an example of those educational events, we have a webinar coming up on September 27th, sponsored by our member Accenture, how healthcare leaders incorporate environmental, social, and governance properties into practice. And I know we have another one. Bianca. Yeah, so another example, we have ours September 29th, defining your organization's path in analytics, creating an analytics center of excellence, sponsored by our member Milliman. So, all right, that is my EHI spiel. I'm going to hand it off to Amanda and Anita.
All right, thank you so much, Emma. I have to say, I love these policy briefings every month, but this month, the topic is so near and dear to my heart. It has been, I think, at least 15 years that I have been talking about the need for interoperability at cocktail parties. You guys have a lot of fun to have around, obviously. And it's fascinating to me how much the conversation has changed and at the same time, how much it stayed the same for those years. And super excited to have Anita with us today. Really looking forward to this. And, you know, we do talk a lot about interoperability throughout the health IT industry, but how do we measure it and why should we? So Anita Samarth is joining us today. She is the CEO and co-founder of Clinovations Government and Health, like Emma mentioned. But what Emma didn't mention is, among other things, Anita is also a past program director here at EHI. And we're super happy to have her back here. So Clinovations Government Health was awarded a contract from ONC to lead an effort really to create a national framework regarding interoperability measurement for health IT products. And so as a part of this, Anita and her team have been bringing their expertise to perform stakeholder outreach, data collection, and lots of analysis of findings among all health IT developers, customers, and other stakeholders in the industry. So super excited to hear from Anita today, and then Immediately after Anita's presentation, we're going to save about 10 minutes or so for Q&A and open discussion. So you'll see the Q&A and chat box on your screen. Please don't hesitate to pop questions in there as we go along today. And with that, I'll hand it over to you, Anita.
All right, thanks so much, Amanda. Yes, great to be back in the EHI sphere. So, all right, let's next slide view. One more. So thank you for that introduction. So you all have access to slides, you know a little bit about me. I think I will only add that I've implemented EHR's HIE at probably over, I think the last count was definitely over 200 organizations nationwide over the last 25 years. So seen a lot of different products and integrations. And I have at the bottom of the screen a little bit of background on Clinovations Government Health and really where we operate, which is often in strategy and governance around technology solutions, technology implementation. So you've got, once you've put together your strategy, you've got many different technologies to implement. And then the last, which is near and dear to my heart and relevant to our convo today, now that you've got all these technologies implemented and all this data that's electronic, how do we actually use that interoperable data? So those are areas where we focus. Let's go to the next slide and talk about the project. All right, so we talked about national approaches and frameworks for interoperability measurement. Maybe not as often. I think I'm in circles where I hear about that often. ONC, you may be familiar with 2 interoperability measurement initiatives that were already in progress. So just want to differentiate the project and the activities we're working on from the EHR reporting program, which was part of the 21st Century Cures Act, where developers, so you'll hear me go back and forth between developers and vendors interchangeably, but those developers will need to submit a common set of measures. And there's been a whole public comment and process to identify those measures in the EHR reporting program. And then there's another part of the final rule that involves real world testing, where developers will design and submit their own measures. Our project is actually a layer on top, or looking further out than these 2 initiatives. I think I saw a chat message flip by on slides. We'll certainly make them available at EHI so that you have these available to anyone attending or members. Let's go to the next slide, Bianca. So the project that we are working on, I'm really pleased to be collaborating with HIMSS as an outreach and engagement partner, which has led us to directly engage with EHRA as part of this project, which is funded by ONC. And we are in the 2nd year of our project, actually getting close to closing it down. And it is something that I haven't seen in the industry federally in a long time. It is specifically a project to engage with industry. So the project is titled Interoperability Measurement by Health IT Developers. So our first year of the project was spent on talking to a number of developers as well as customers and looking at their products and understanding interoperability capabilities as well as measurement capabilities, or even in many cases, the lack thereof. And this year, we focused more about thinking about future measures 3 to 5 years into the future. One aspect of the ONC project, while today I am happy to talk about larger interoperability measurement capabilities, this project has focused on reporting or capabilities out of EHR or certified health IT technology, since that's the area in ONC's purview right now. So this project this year has focused more on co-creation. So we're applying the findings from the first year and working with the developer community, as well as conducting a series of roundtables to identify and develop future measures. Let's go to the next slide. Okay, this is, I know everyone here today is very entrenched in health IT, but this is one of my favorite analogies, and I think probably it's because I've come through multiple home renovations, right? Why measure, right? I feel like most stakeholders, we hear a lot about, oh, I don't get what I need, or I'm getting too much data, et cetera, et cetera. I love to use this water analogy. While water could be coming from many different sources, and just for fun on the left, think about all the faucets in your house. You have your sink faucet, maybe you have a drinking water filtered faucet, you've got your shower, you've got outdoor hoses. And let's say they were all turned on. You'd be like, great, we're successful. There's so much water flowing. We're great, we've met our goals. But have we? How do we measure whether all this water or data that's flowing is successful, what the impact is, what challenges remain and gaps? And you can look on the right, I won't read through all of it, but like, okay, you have all this water. Is it being used? Is it useful? Is there enough of it? Is there too much of it? Can you control it? Who controls it? Where does it get controlled? Where's it going? So if you use some of it, when you don't use some of it, where does it flow off to? What happens to it? And what happens to that water that's unused? So in this analogy, if you replace water with data, you kind of get back to how do we really apply some understanding to the commentary we hear about what is and is not working in the area of interoperability. So hopefully that gets you your stage set. Yeah, great. So I won't go through this slide in detail, but if you think about the data water or the data that's flowing, we've got a lot of different types of data. And you're probably familiar from many of the ONC and other interoperability frameworks, this whole notion of there's sending and receiving of data, there's querying or searching and finding of data. Once you've received or have access to that data in your EHR ecosystem, you have actions that need to happen to incorporate and reconcile that data. But then on the far right here, it's much more complicated to really get to measurements of use and impact. And on the left, I would say 2/3 of the screen, you're seeing lots of different transactions, standards, and sometimes there's different transport mechanisms, there's different payloads and content. And there's different stakeholders that are exchanging this information. We even have a ton of different networks and HIEs. So where do you actually put your measurement instrument to measure? So that's what we looked at in the first year. Next slide. So to simplify, the left interoperability domains that you're very familiar with, when you think about measurement, you have to think about what's really happening. So we grouped some of the ones in the top left, so the send, receive, find, and query, to more of this transaction measurement, because that's a measurement of transactions. Back to that water, what's the volume of water that's flowing? Hey, there's water going back and forth, right? If you're incorporating data or you're reconciling data, you've got someone is actually taking an action on that data, right? But beyond the action of reconcile, is it being used? Is there decision-making happening? We propose that that is a reaction. And last but certainly not least, if it affects outcomes and really has that impact, that interoperable data is really having some traction. So we personally like the alliteration, but as you start to think about measurement of interoperability, we're looking at measuring transactions, actions, reactions, and traction around this data. Next slide. Okay, so this could take 30 minutes and I'm gonna try to do it in less than 3. In our first year of the project, and there will be some public components that'll be available. When we looked at whether interoperability measurement or measures can be ready, valuable, and comparable. So you'll hear our value, comparability, and feasibility a lot from me here today. We know that developer product architecture varies, so inherently how interoperability is built into the system. Even things like national networks, carry quality, Commonwealth, eHealth Exchange, direct, right? Whether the vendor takes an active role in connecting their customers or more of a passive role, or even regional variances around participation in those networks. There's a lot of variability there. Developer product functionality, and we'll have a lot of time to go into this, but can data once exchanged, is it automated matching or linking to the patient? If you're getting the same data, that CCDA that gets generated in result of a transition of care or a discharge summary that maybe gets pushed by a direct and is also available via maybe a Commonwealth query, and maybe also part of ENS notifications through more of an HIE. Are you getting that same CCDA or the data in that CCDA 3, 4, 5 times? So what type of automation support and deduplication exists to sort through that data that might be duplicative or is coming from many directions? We saw variances in provenance tracking. Once that data is incorporated in your EHR, do you know where it came from? And there are some criteria that are coming along around that. And then the other ones I'll go through quickly. Obviously, different markets and business drivers in terms of which functionality or why certain types of exchange are supported or not. I'm here in the District of Columbia, where we maybe have we have a number of community health centers, for example, that have behavioral health data. So there's been some work to really think about, well, what kind of data is in the EHR before you're participating in national network-based exchange. Customer tools and reporting of interoperability and architecture varies. And then obviously going back to customer implementation, you can, what did you map to make available via CCDA or other documents, right? Or other FHIR-based API calls or even into PDFs. That's going to vary. So hopefully, I think I did that in about 3 minutes, but happy to talk about any of these factors. So this makes measurement even tougher. Let's go to the next slide. So in our first year working going into the second year, we had to streamline and really focus on a couple of categories. So this year of the project really focused on 4 areas. Expanded transaction measures. So again, that's more of the volume, but there are some areas where it could make sense to exchange, to measure certain types of exchange connections to public health. We've learned a lot post-COVID, so that we could get some numbers so we can understand what direction, what data is flowing in. So there are some types of exchange where we still need that transaction level measurement. Patient data measures, even patient generated data measures, those were one category. The third category, which may be new to most folks, is this concept of utility measures. And that is a measure around not certified or required functionality, but I talked about that dedupe and the automation and the linking. What kind of capabilities exist to scrub or look at data interoperable external exchange data that help reduce user burden so that you aren't flooded with that sets of water and you're not drowning? I'll have to take that analogy a little bit further. And then last but certainly not least, decision support and care management measures. Did this external data have an impact? Did it have an impact of reduction of duplicate orders, or were care gaps filled? And that's really a reaction type measure. Okay, I think I can go through these fairly quickly. As background, I noted we've had a number of work group meetings with EHRA standards and certification, standards and interoperability and certification work groups. We've had a couple of roundtables with consumer perspectives, representatives, provider orgs. We worked with HIMSS to use a number of, to work with a lot of MRAM stage 6 and 7 and Davies Award winners, so really advanced users of health information technologies. Some HIEs and national networks, so Commonwealth, Care Equality, Direct Trust, others. And then app developers, both patient-facing and provider-facing app developers. So these are some of the input forms so that we can understand the readiness and preferences and needs. Next slide. I think this is my last slide, so this will take us into discussion, which is the type of feedback that we seek, and would love feedback here today or any mechanism offline. I've got in the slides our project email box as well as my email. The industry feedback we're really looking to find and hear more about is, I ask groups, and I'll ask this group here today, what do you think about the state of interoperability today? And often we hear, oh, it's great, or it's better, or I don't have what I want, right? And so when you start a more general conversation around the state of interoperability, you can easily sort of move into, well, is this how you feel, or do you know? And what do we know? And what do we not know? And everything doesn't necessarily have to be a measure, a percentage-based measure, a count measure, or a ratio. Sometimes we may be looking at what information do we want to collect? What kind of transparency do we want from either EHR vendors or providers to understand how interoperable data is moving or used? And then the third area really gets into, okay, let's start to talk about measures that can really quantify both progress and gaps. And then we don't want to lose sight of ensuring that we have value and insights, and thinking about comparability. What needs to be comparable, or what do we just want to learn more about so that we can understand? And I use examples like, in other industries, or even the utilities space, where we have certain measures that give us a sense of magnitude, and then we have other measures that really get us more specific insights. And I heard this statement that I'll share is, you're really only going to look at a report if you know you have a problem. So, I've got some questions kind of popped up here, and I know Amanda has questions for me. So, we had 20 minutes to run through this kind of quickly. Hopefully, it gives you guys a little bit of a flavor and gets you thinking. And I will look at the chat, and there's a lot of questions.
Yeah. I'll pull some up here for you, Anita. Thank you for that. I have to say, you are the best I've ever seen at getting through a ton of dense information in a very, very, very fast amount of time. So we do have several questions, and I'll start with some specific and logistical questions, and then we'll move to maybe some bigger landscape and philosophical questions, perhaps. Starting with, there's a question from Matthew Flores. Does customer here refer to clinicians and facilities only, or the payer domain as well for payer and payer exchange?
Great question, Matthew. At the initial start of the project, we did focus on provider organizations and end users of the EHR. That being said, when we talk about interoperability and we talk about what type of measurements are helpful, real-time benefit checking came up, certain types of payer change. I'll say this, the ONC specific project hasn't focused on the payer specific transactions. So, but part of this larger conversation is collecting those examples of from different stakeholders of measures that would really be helpful. So,
yeah. All right, next question up. We've had a few questions come in regarding TEFCA and how does TEFCA impact interoperability measurement and the goals of this project?
Yeah, great question. If you saw me laughing, because I will take this one, maybe Amanda, I'll talk about TEFCA first, but kudos to whoever said, I thought you were talking about interoperability. Why are CCDAs coming up? So I will tackle that. But looking at impact of TEFCA, I mean, TEFCA is a critical infrastructure for HIE and cross-state and cross-region, so that we can have QHIN to QHIN based exchange. The opportunity in this project and the focus has been, well, as you look at that water, if the water spigots are on and you're getting everything to connect together, at the end of the day, at least from a provider, and even I would argue from a patient API-based apps or portal standpoint, there's still an end user set of technology. And so that is why the project as a starter focus has focused on certified EHR or certified health IT. And so I would say as TEFCA evolves, and if that starts to move something to a place where ONC or another agency has more regulatory purview over the entities themselves, then we can look at than I expect. And again, I should say, you all know I'm a contractor, so I don't speak for O&C, but I can speak from what we're seeing in the industry. We have so much to understand with the data that's flowing right now. And so, we didn't really focus on measuring one particular pathway. So TUFCA is going to be yet another pathway by which that data gets to the EHR or gets to that certified health IT to be available for providers, to be available for patients, available for payers. So, I would say that we haven't been ignoring TUFCA, but it's been purposely in parallel because we're in an advanced stage of potential for measurement on the EHR vendor side. Amanda, do you want me to take the CCDA question?
Yeah, absolutely. Go for it.
Well, my favorite example, and I'm sure everyone here is going to roll their eyes. I hate those ATM analogies. I promise I won't do it. If I had a dollar for every time I heard why can't we, do things like ATMs? But if we take it aside and say, what we defined in financial services is we define the use cases. While we can use our bank card at any ATM, if I'm out of money in my Bank of America account, it doesn't go and check my Wells Fargo account and say, oh, well, she's got money over here, I'm going to go pull it out, right? So when we define and we talk about interoperability, what I find really interesting, and we've done a lot of projects, we've looked at a lot of different industries and evolutions of standards. Healthcare is one of the few industries where there's a whole notion of interoperability means everything is computable, exchangeable, usable. And we have very few places in which that is the case. And so, why are we talking about CCDAs? It's a standard document type. We talk, if you look at the transactions, I noted not only the transport mechanism, but the payload. So it could be FHIR, it could be CDA. We need to actually have measurements. And this project actually came out of a component of Congress that required O&C to have measures so that we could see where we are, and we can actually have some measures around interoperability. So if someone wants to push me harder on that CCDA, totally get where you're going, and even in some ways agree with it. But I also am very happy to see the industry converge on the use cases, and I'll add on the patient side. When we talk with consumer groups, there are specific patient types that need certain types of information. So we all kind of go back and forth of, if we looked at the measures of how many patients have connected third-party apps, or we looked at how many requests there have been, et cetera, and this is again me talking, I don't know that those numbers will be extremely higher, they're probably even low, but you have certain populations of patients that really do need those, need access to their health information. And it is something that we're hearing about, which is much more from the consumer side. There were less about interoperability and can I get the PDFs? Can I get the data? I don't even want to be limited to summary data sets and CCDAs. I would be happy if I just got PDFs, right? Versus on the EHR developer or other groups, when they think of measurement, they're thinking of, well, let's measure the things that we're required to do as we look at standards ahead. So I could keep talking about that, but Amanda, what do you want to, what's your next question?
That's great. Well, you mentioned certification criteria, and we've had a few questions come up around that area. And you've already given the disclaimer, you certainly don't speak for O&C in any way, but based on your observations and your personal well-informed opinion, do you think that new interoperability certification criteria are needed to advance the current state? And if so, in what areas?
Oh, yes, I'm definitely speaking on behalf of myself. I've been a vendor too. So while I would consider myself an implementer for the majority of my life. I spent a little bit of time as a vendor and, working in the policy space. Thank you, EHI, for introducing me to the health IT policy space. Do we need more criteria? Yes, but I think, I am seeing quite what we hear, or what I'm hearing from the provider market is we have so many things we're required to do. And we're also hearing that from the vendor market in terms of, we have such a long roadmap of things that we have to be required to do. So I think that we need to continue to evolve our use cases and identify what we're going to prioritize. I think it's a tough question on, do we need more criteria? We've got to decide as a country if our criteria is going to focus on just setting the bar and setting either the floor, or are we going to start to move to set the ceiling and start to record data? So I would say, sure, yes, we need more criteria, and criteria doesn't necessarily mean we need threshold measures around it. I'm just going to look at this question. Do we need more criteria, or is it better, higher quality criteria? We all know that there are data types that are not incorporated, right? So I think this is a continuous improvement process of identifying the use cases, but this is my personal opinion. Not every use case needs to be handled by everyone. I think someone just put specialty specific criteria. I think I really hope that we're able to look to industry and users of the data to define those requirements and really advocate for those requirements, because I think we're seeing it come out of the policy landscape, but it'd be great to see it come from those that really need it. So I'm sure I can definitely say that different stakeholders absolutely need more criteria. But I can appreciate the challenge and the burden placed upon the developer community. So it's chicken or egg. So I guess I'll go on record by saying yes, more criteria and higher quality criteria, but we have to figure out how to do that in a feasible way.
Sure. Thank you for that. And I love that you're not afraid to take the give the hot take answers here. And I see that we are about out of time here. As we wrap up, Anita, is there any final thought that you'd like to leave us with?
I like all these analogies, so I'll leave you with one more. The challenges in, I'd like to leave it on a positive note. I'm not sure if this does this, but one of my biggest frustrations from an interoperability standpoint is calendaring. So those of you and us that use like GCal versus Outlook versus iCal, on the Android, we're talking about 4 data elements: start date time, stop date time, subject, and attendees, right? Or duration. And I find that we still are in a world, because we do have different market choices, where some things probably don't need to be that challenging, but can be a little bit challenging. We don't have measures around that. We can't quantify how often a GCal invite doesn't sync onto my Apple iPhone. So we've got to kind of think through where we want to focus. And right now, I think that there's a lot out there, and I think that's difficult. And and maybe as an industry, hopefully if we can come together. I don't think this is likely, because I think we're going to have a lot of needs, but there are a lot of needs, yet you can't really make progress at a national level without some focus. And there are a lot of other questions in here. So happy, Amanda, to take them offline, or even put them in something public. I'm happy to do that. Yeah.
Great, absolutely. And I know that at the very least, as Emma said in the chat, these slides will be available along with the recording of this webinar in the Resource Center later today. And that link is there in the chat as well, and includes, I believe you said, the project email address. So you and your team open to additional questions and comments and feedback, right?
Yes, you can send my way. I recognize a lot of the names. Great to have you all join today. Thank you, everyone.
Fantastic.
Thanks for joining me over lunch.
Yeah. Thank you. And we'll see you all back next month.
Okay. Bye.